record. And everyone has to say yes. Start with some introductions. So first of all, if you are not sharing your slides, would everyone please be sure that their screens are on the gallery view so that we can see each other, because we are part of one community. So my name is Rhea Markowitz, and I'm from the Georgia Cancer Center, and I'm part of the hub team for teledermatology. Dr. Doug Patton and I will be serving as co-facilitators of this TeleECHO session today. I want to welcome our participants. And so as I mention your name or your group, if you could wave so other people can know who you are, that would just very great. So first of all, we have family medicine people, residents, and possibly some faculty. So they are in the classroom up there. Wave, hello. Okay. We have primary care providers from our clinics and the staff at our TeleDerm clinics. So if you can wave hello so we see who you are. Or turn on your cameras, because I see some of you do not have your cameras on. So hopefully you will.
Can you could you speak more closer to the microphone? So yeah.
Oh, okay. Is that better? Can you hear me? Okay. All right. Let's see. We have our dermatologists. We have Dr. Davis. Wave hello. We have Dr. Rabinovitz, and we have Dr. Buchanan. So they are our expert dermatologists. We have dermatology residents, and we have some medical students on board. And we have, I don't know if there are any AU nurses out there who are joining us today. Sometimes we do. And then we have other members of our TeleDerm team. We have those of us here in the hub. We've got Kenza Mamuni and Marisol Miranda handling the controls. And we have Mackenzie Maloney, a medical student sitting behind me. So welcome everyone. So that we can all get to know who we are. If you can all write into the chat your full name, your email address, and your affiliation, whether it be one of our clinics or your department here at AU, whatever, and there should be an example in the chat already. So I will review today's agenda with you. We will have our little introduction, and then we will have a presentation by Dr. Kendall Buchanan on patterns of Nevi, and a few minutes for questions. We will do our first case presentation, and we flip these around. So our first case presentation for today will be by Dr. Davis Diamond, who is a third-year resident in dermatology. And then Dr. Buchanan will do a case presentation, and then we'll have a wrap up and announcements about the next session and so forth. Point out that not only is this Dr. Diamond's first presentation, it's also his first time attending one of our TeleECHO sessions. So we really thank him for stepping up the plate for us. Now, before we continue, Dr. Buchanan wants to say a few words to the primary care providers in our clinics about changing the way we're doing the derm consults. Kendall?
Hey guys, I just wanted to let everyone know that I'm going to be sort of the primary reader. I'll still, of course, be able to communicate with Dr. Rabinovitz, especially if we have any challenging cases. But I would just encourage you guys, I'm available. I can, hopefully look at these within about a 5 or a 10-minute time span, depending on if I have or if I'm actively seeing patients at the time. But, I plan to try to get you guys a response as quickly as I can. So, I just wanted to let everyone know that, through the Derm Engine platform, you can now select my name. So I look forward to working with each of you. I think you guys all have my phone number. You can call me, text me, email me, and just let me know whenever you send a consult.
Okay, so now I am going to turn the program over to Dr. Doug Patton, who will continue. Dr. Patton is the Dean of the Southwest Georgia Regional Campus for the Medical College of Georgia, and he has spent most of his career as a rural physician. So Doug, take it away.
Thank you, Rhea. It's my pleasure to be back with you guys again, and thank you so much. Thank you, Dr. Buchanan, for that opening to assist with the teleconsults and turning those around so quickly when possible. That's incredibly helpful for the providers, I know. So we'll have the next slide and we'll kind of move through some of our normal things. Again, just a reminder that the whole business behind Project ECHO is moving knowledge instead of people. It's the extension for community healthcare outcomes. And this is nothing if we don't have the participants, because you guys are part of the educational process. You get to share. Next slide. So it's collaborative in that regard. And we use this platform to create learning loops. So it's not just pure didactics. We hope that you're fully engaged, that you ask questions, and we'll get to that in just a second. But that also in time that you will feel comfortable sharing cases with us as well, so that you can be one of the case presenters. This was developed by the University of New Mexico. It's a little over a decade old, and it works across multiple areas of medical specialty. And you can check that out at echo.unn.edu. Next slide. So this TeleDerm sessions that we have through Project ECHO are helping to empower you as primary care providers at the local level through these distance learning techniques to learn about, to address the dermatologic health disparities that are faced by people who live in rural areas, in areas where it's difficult to access dermatological specialty care. Next slide. Just a reminder that this is for education quality improvement purposes only. These sessions, as opposed to the TeleDerm or the Derm Engine consults, these sessions are educational and not designed for consultative purposes. So please don't mention PHI in any of the presentations or discussions. There'll be information in the chat later on for CME and CNE. And you can always email questions. If you can put them in the chat, or you can email to teledermatology@augusta.edu. Next slide. We do use data from registration purposes, from the chats, from everything, from poll responses, any questions or anything like that, as well as the recordings for any number of reasons. But the most important of which is to improve our own presentations and inform any new initiatives that might surface as a result of our joint participation. Next slide. So general Zoom reminders, again, keep your cameras on if possible, if your bandwidth can stand it. We're actually having some network issues here on the Southwest campus today. So I hope that I don't experience any sudden departures, but if I do, I'll come back to you as quickly as I can. Mute your microphone if you're not speaking, and certainly during the presentations. During the presentations, if you have a question, please put it in the chat. We'll monitor that carefully and try and address those during the Q&A period. When we're having open Q&A, please raise your hand electronically by hovering over the reactions button towards the bottom of the Zoom screen. You'll see the raise hand button. Raise that. Once you're identified, then introduce yourself, where you're from, and ask your question. The cameras are important. Please keep them on if possible. And again, using the gallery view helps us to see as many faces as possible throughout the presentation. And again, if you're having technical problems, you can email those straight to Kenza at kmamouni@augusta.edu. Next slide. I think that's the end of our homework slides and basic slides. So at this point, it's my pleasure to reintroduce to you Dr. Kendall Buchanan, who many of you have met on previous presentations. She will share with us today about patterns of Nevi. She is faculty with Augusta University and practices in the Aiken Center across the river from Augusta. Dr. Buchanan, I'll turn it over to you.
All right, can you guys hear me? Okay.
We can.
Okay, perfect. So today we'll be talking about the many faces of Nevi. So this will be part one of a two-part series. So we didn't review this particular algorithm, but I like the way it looked. So I wanted to show this today. This is available for free download at dermoscopy.ch. But today we're going to be focusing on benign nevus patterns. Okay. We won't go through all of these patterns today, but next month we will talk about some special types of nevi. So we're going to kind of do a quick recap from last week, just because last month, because we talked about pattern analysis. And this is really important whenever we're looking at benign lesions, particularly nevi. So as you recall, we talked about how do we differentiate benign from malignant lesions. So the three main ways are through color, symmetry, and organization. And so this is just an example here of the differences between a benign nevus and a melanoma. So in general, benign nevus will be symmetric, well circumscribed with smooth margins, and have aggregations, or what we normally refer to as dots and globules, that are usually uniform in size and shape. Contrast that with a melanoma, which is going to usually be more asymmetric, poorly circumscribed with irregular margins, and have dots and globules that are very either atypical, multiple sizes, and be distributed irregularly throughout the lesion. And this is just a schematic here, and we'll go over this particular type of nevus pattern, which is called a reticular nevus. And you can see how, compared to a melanoma, you have these, thin brown lines that sort of fade at the periphery. And then with the melanoma, you have multiple different colors of lines. The holes are different sizes. You also have a different diameter of the lines. And these are all clues that you might be dealing with a melanoma as opposed to a nevus. So in terms of colors, you'll recall we talked about blue, brown, black, red, yellow, and white. And you can also have different shades of brown. So the three most common colors are light brown, dark brown, and black. And remember, in general, nevi usually have, 3 or less colors, and melanomas typically have more colors, as you can see the differences in these examples shown here. And then symmetry, asymmetry. Remember, we're talking mainly about the pattern. So when you're looking under your dermatoscope, what type of pattern are you seeing? So usually with benign lesions, you'll have biaxial symmetry or monoaxial symmetry. And then with malignant lesions, they'll typically be asymmetric on both axes. And again, this is just the schematic of the example showing that a shape, the lesion can be symmetric, but the pattern can be asymmetric. And also you can have a symmetric pattern, but the shape can be asymmetric. And these are just some examples here that I showed last month. Okay. And then organization, disorganization. I think this is actually really important. If you can look at something and just, based on how we kind of see beauty, if you can look at something and be able to just kind of tell whether it's organized or disorganized, that will actually get you a long way with dermoscopy. And so again, organized are going to have uniform structures, and it should conform to benign patterns. Something that's disorganized, as you can see with these two examples of melanomas, you have departure from benign patterns. It's asymmetric. You have this atypical blotch located at the periphery. So overall, it's a disorganized pattern. And then this is something that it's called the Beauty and the Beast sign. So, you know, the definition of beauty is basically something that's pleasing to the eye. And I often tell patients, you have a beautiful mole. Whenever I see something that looks very nice on dermoscopy, and patients like that. So, okay, so now we're gonna kind of dive into the benign nevus patterns. And so this is just a schematic here of the ones that we'll go over today. Just, you know, quickly glancing at it, you know, you can focus on the symmetry, the colors, you know, everything is based on that pattern recognition that we talked about. So try not to focus too much on, you know, necessarily what you're seeing, but just on the overall pattern and how it looks organized. Okay. And then we'll talk about these 10 features to aid in the diagnosis of Nevi as well. So the first one is a reticular pattern. And so as I pointed out in the first example, you can see how there's multiple lines, the brown lines, which correspond to the pigment that's in the reedy ridges, and then the holes, which are representative of the dermal papilla. So everything is uniform. The lines tend to fade at the periphery. That can also be a helpful clue. And these are just some more examples here. These are clinical images, and then, you know, try to focus on, you know, just organization, because if you go too deep in these, you can start to say, well, are those holes really the same size? But, you know, you really want to focus on how it's symmetric, has minimal colors, and then it has an overall benign pattern. Patchy reticular, very similar. You just kind of have spaces where there's not a clear network, but overall the patches should be of similar size and shape. And again, you would expect the holes that correspond to the dermal papilla to be similar in size and diameter. And the line should be relatively the same as well. So these are some examples of the patchy reticular pattern. And then our next one is what we call a peripheral reticular network pattern with central hypopigmentation. We'll talk about this more next month, but these are often seen in patients with lighter skin types. But usually this central area will be lighter in color than the network, but darker than the surrounding skin. And here are some more examples shown here. So, but again, symmetric, organized, few colors. Try to keep that in mind. This is kind of the opposite of that. So peripheral network with central hyperpigmentation. And these are often seen in patients of darker skin types. And so you can actually, sometimes what we refer to this typically as a blotch because you cannot see anything underneath, but you can see that, you know, it's symmetric. You have the peripheral network, which fades at the periphery. Occasionally you can use tape and sort of remove this, what we call a lamella that's on top, and you can sometimes see the network underneath. That's not always the case, but usually that happens whenever there's melanin in the stratum corneum, which is the top layer of our skin. So sometimes that can be a helpful tip. But overall, these are very benign appearing, and like I said, usually seen in a patient with a darker skin type like Fitzpatrick's 4 through 6. The next one is a peripheral network with central globules. So again, same uniformity that I've talked about. And in this one, you have the globules, and you know, sometimes we use dots and globules interchangeably. They pretty much are. They just sort of refer to the size of these tiny brown dots. But again, they should be very similar size. And in this type of nevus, they're located in the center. And these are just some additional patterns here. Okay. The globular pattern, this is This is pretty common type of nevus. We usually see this more in congenital nevi. And you can see how these globules are just distributed evenly. They're very similar in size and shape. And usually these are more, nest of melanocytes. And these are some more examples here, but very organized and beautiful. This is a specific type of globular pattern. I just show it more for completion. If you kind of think about cobblestones, it has the sort of more angulated edges. And these are often seen in congenital nevi, but still very organized. But, think if you could just kind of hop from one to the other. I don't know. They do look like cobblestones. And here's some more examples here. You can also have a peripheral globular pattern with a central reticular area. And these are usually whenever you have globules and streaks that we'll talk about associated at the periphery, that's sort of an indicator of growth. So usually, we're really comfortable seeing one row of globules because that's usually a feature of these benign nevi. But you do have to kind of be careful in an older individual, especially if you saw this type of pattern on the lower leg or in an area that was atypical. You would need to consider melanoma. But again, this type of nevus pattern is benign. And here's some more examples here. Okay. The homogeneous blue pattern, this is, I would say, pretty specific to blue nevi. The main takeaway with this is that you don't want to confuse this with a blue-white veil, and that can be hard. But one thing to keep in mind is that this should cover the entire lesion, and compared to a blue-white veil, which we see in melanomas, that would usually be focally located or at the periphery or on the raised portion of the lesion. And sometimes you would also be able to see, or typically you would see other melanoma specific features. And the reason we see the blue nevus has melanocytes, but they're located so deep that what you're seeing with your eye due to the Tyndall effect is blue. Okay. So if you ever are concerned about a blue nevus and it's pretty small, then I would say do a punch biopsy, because if you do a shave, and I'm just as guilty, but I've done a shave before and you see pigment at the base and it can be really scary. So try to do a little punch biopsy if you are thinking that it could be a blue nevus or if it's for cosmetic reasons. And these are just some more examples here. And then similarly, you can see this homogeneous brown pattern. I think the main takeaway from this is that you don't really see any other features. So no other melanoma specific features. And we'll kind of go into detail about that. But these are just kind of banal appearing. There's other patterns, of course. There's always exceptions. This is just an example of a multi-component pattern. And then this is an example of a 2-component pattern. So, some of these are a little bit more challenging, and you'd have to kind of definitely take into the context where it's located and have your clinical history for that patient. So these are the ones we went over today. Okay. And then, like we talked about, departure from benign patterns helps us detect malignancy. So we're just going to quickly go through the 10 important features to help aid in the diagnosis of nevi. So these are just examples, departure from benign patterns. So on the left, you see a typical network. On the right, you see the network is focally located at the periphery, and you can see the lines are different colors and they're different sizes. Okay, so that's more seen with the melanoma. Symmetrical streaks. We didn't specifically talk about Spitz nevi today. We'll do that next month, but if it's symmetric and usually in a child, it's usually okay. But as you can see in this melanoma, these streaks are located at the periphery. That means this lesion is growing, and you should strongly consider a biopsy. And this lesion example here has other melanoma specific features too. Okay. And then typical dots and globules, like in this example, the dots and globules are centrally located compared to a melanoma on the right, where you have this kind of focal areas like focal dots, globules. Similarly, in this case, you have multiple globules located at the periphery with some early streaks. You also have, blue kind of gray areas as well. So multiple colors should think about melanoma. So lack of a negative pigment network, we'll go into this in more detail in other lectures, but this is an example of a schematic where your melanocytes in the nest are more curvilinear and elongated. And then you have this white kind of interweaving like pattern that goes in between. The reason that's important is because you often don't see this type of negative pigment network with melanoma. And so, or sorry, with Nevi, and you can see it in certain types of Nevi, but if you see it, it should just raise your suspicion that this could potentially be a melanoma. And you can see it in this example. It's kind of the reverse of the typical reticular pigment network that we usually think about. Okay. Shiny white lines or crystalline structures, these are usually indicative of dermal fibrosis, collagen production, that sort of thing. You can see it in some nevi, not as common, but this would be something that if you saw, especially along with other melanoma features, atypical network, angulated lines, multiple colors, that you would definitely want to think about an invasive melanoma. And you can see these are often orthogonal or angulated and usually at like 90-degree angles. They're sort of short and small. Central blotch, as we talked about, if it's centrally located with no other melanoma specific features, it's most likely going to be that particular type of nevus pattern. Peripheral reticular with central hyperpigmentation. But in this example of the melanoma on the right, you can see it's focally located, asymmetric, and just overall representative of a disorganized pattern. Gray dots granules, these, if seen in nevi, typically tend to be focal, so less than 10%. Or sorry, not focal, but centrally located and usually less than 10%. As you can see here, they're in the center. And then compared to a melanoma, often these can sort of indicate regression. And so you can see here, you just have other melanoma specific features, but also this sort of gray dots granules. We sometimes refer to this as peppering. Okay, and these are just sort of melanin, like pigment incontinence. The blue-white veil, like I was explaining earlier with the blue nevus, which is shown on the left, if it's, overlying the lesion and it's not off center, this is a beautiful blue nevus. And then compared to the right, you see this blue-white veil. That's, a blue-white veil, you should be able to palpate that. So, because this is sort of your more like invasive type of melanoma. So if you can palpate the lesion, you can call that a blue-white veil. We often sometimes will say that it's a blue-white veil, but actually it's regression structure. So regression, like the gray dots granules or peppering, that's usually flat compared to the blue-white veil that's usually raised. Okay, and this is actually seen better with non-polarized light. And I know you guys have mole scopes, which are polarized light, but with polarized light, you should be able to see some shiny white structures. Okay. And then these are just some more examples here. And then vascular structures. We did not talk about intradermal nevi today. We will talk about that next month, but they can have these comma-like vessels. Sometimes they can also appear just overall to be a little bit disorganized, but usually your patient is going to have a history, like say Dr. Buchanan, I've had this all my life, it hasn't changed. And then you can see in this photo on the left, these little comma-like kind of curvy vessels. Compared to a a melanoma, you will often see polymorphous vessels, and that simply means vessels or two or more vessels. So usually with melanoma, you're thinking about vessels as dots and linear irregular vessels. I think we talked about that maybe the first week that I did a case. Okay, so just kind of keep that in mind, especially in this example when you're also seeing other features that you see with a melanoma. Okay, and then the last part is tan brown structureless areas. I find this to be pretty challenging sometimes, but actually these are associated with the highest odds ratio, up to 27, I believe, of being a melanoma. So these are pretty important if you can kind of train your eye to pick them out. As you can see in this nevus, you have this sort of tan area. You can't really see much else beneath, like no specific structures, but it's located centrally. You have a very benign appearance, very organized. And then with the picture on the right, the melanoma, you have this very large tan brown structureless area. And then you have some other, other areas where you have like an atypical network, and that sort of thing. So just kind of keep that in mind when you're looking with your dermatoscope. So again, just to let everybody see the benign nevus patterns here. And so today we reviewed the most common benign nevus patterns, and then we reviewed the 10 most important criteria to aid in the diagnosis of nevi. And then next month on August 1st, I believe, but Rhea can correct me, we will do our next session on part 2. And we will talk about what influences nevus patterns and special types of nevi. And I was thinking about adding this today, but other features, kind of clues to differentiate nevi from melanoma. And so these are my references. I have to thank Dr. Rabinovitz for being the best mentor, and I'm trying to be the best protege. But he is responsible for, all of my training and any sort of education that I can give you guys. So thank you.
Well, thank you, Dr. Buchanan, and thank you, Dr. Rabinovitz, for helping us to bring along a new generation of experts. So that's terrific. I don't see any questions in the chat, but we certainly have a couple of minutes here, and I would love to entertain any. And you can do that again by hovering over the reactions button and raising your hand. And we'll try and see if we can identify any participants who have a question. I just wanted to get some clarification, Dr. Buchanan, real quick. Oh, wait. Oh, that's the list of folks from family medicine. Thank you, Anthony, for providing all that. So all the images that you shared, these were dermatoscopic images, correct? These weren't just plain camera views, correct?
Some of the images were with a zoomed in, like Nikon camera. Yes,
Okay.
sir. But then I tried to specifically focus on the dermatoscopic images because clinically what normally draws you to something is that, it should look disorganized whenever you put your dermatoscope on it. And so, you won't really be able to see a characteristic network or any of the specific features that we talked about today unless you use your dermatoscope. And I have a case that I think does a good example of pointing out some of this a little bit better.
That's great, because I think sometimes when we get busy and we're looking at something in the clinic and we see it, we may not appreciate that, which is why it's nice to have the scope handy and be able to put it right on it and take a look, because it accentuates some of these characteristics that you were talking about. All right, I don't see any other questions. Am I missing anyone? Scrolling through. All right, well, you guys be sure and hold your questions and your comments, because we hopefully will have some time at the end, but we want to keep things moving. So today it's my pleasure to welcome Dr. Davis Diamond, who is now officially a PGY3 resident. It's his second year in Augusta as a dermatology resident. He's a full 11 days into this year of his expert journey. And Dr. Diamond is going to share with us a case today. It is his first TeleECHO conference and his first presentation, but we have every reason in the world to know he's going to do a great job. So Dr. Diamond, thank you for joining us today.
Thank you for having me. You guys seeing the full screen presentation here?
We are. It's perfect.
Perfect. I'm going to talk sort of on the same lines of what Dr. Buchanan was talking about with Nevi, but just a little different here. Something that I think can commonly be mistaken for Nevi, especially when I came in last year as a resident, something that can trip you up a little bit if you're not doing this stuff all the time. So here we had a 52-year-old Caucasian male, comes in with no history of skin cancer, and he's just coming in for a good skin check. But he has noticed a new, firm, asymptomatic lesion on his left third toe that came up around 6 months ago. And, dermoscopically, I really chose to focus on two different features here. First, with the blue arrow showing here, we can see this kind of white structureless or kind of scar-like area. And on the outside here, we just see some kind of peripheral homogeneous kind of hyperpigmented area. And it doesn't really appear like this actually has a pigment network in it. So, and that's just reiterating what I just said. And clinically, this is very firm to the touch, which I'll explain why that's helpful in a couple slides. So we didn't choose to biopsy this lesion. We see these all the time. This is a dermatofibroma, and this is a less common kind of pattern of dermatofibroma. This one's more like that pattern 8 that you can see here on the side. So only about 10% of dermatofibromas will look like that. But I wanted to show you some other pictures, some more common pictures or kind of patterns of dermatofibromas that I think are more easily confused with pigmented lesions, Nevi, and of course, you don't want to get them confused or miss a melanoma. So that's just going back, kind of comparing those two patterns, and why we chose to clinically call this a dermatofibroma, our lesion. But here's some other really good example photos or dermoscopy photos of dermatofibromas. I think the one on the left here, this is the most classic type of dermatofibroma that we're going to encounter, and kind of has this reticulated pigment network at the end, or kind of a ring of this reticulated pigment network around this central white scar-like patch. And this is certainly the most easy kind of dermatofibroma to call out of all the different patterns. But then sometimes the second most common pattern that you're going to encounter is just a totally delicate kind of reticulated pigment network. And these can easily be confused for Nevi. So I'll talk about some strategies to kind of delineate the two of those. So just looking at, this is the most common pattern that you'll see for dermatofibroma. So the central like kind of scar-like or white patch, I think, is the most striking feature of these lesions, and are a very good clue that you're actually dealing with a dermatofibroma rather than a pigmented lesion. And so the scar that you're actually seeing in the middle, that actually corresponds to fibrosis in the papillary dermis. So this is why when you actually feel a dermatofibroma, that feels so indurated or firm to the touch. And then around, we see the ring-like pigment network, which corresponds to pigmented keratinocytes lining the rete. So, and then just to compare dermatofibroma to just kind of like a reticular pigment network in a nevus, the periphery of the dermatofibroma doesn't look all that different than the pigment network of the nevus, but obviously the central white patch helps us delineate here. But then you're going to have lesions that look like this. And, for me to be able to call that one on the left a dermatofibroma over a nevus without touching it, I feel like would pretty much be impossible. So, I mean, there's certainly a lot of overlap in the dermoscopic features. Of the utmost importance, though, it's pretty obvious that these lesions don't exhibit any concerning features that would, make you consider a melanoma, like gray dots granules or multiple colors or an atypical pigment network. So, like I was saying earlier, you're going to need to use some of the clinical features of these lesions, actually putting your hands on the patient and feeling the lesion to be able to, try to tease out whether this is a nevus versus a dermatofibroma. But, overall, the most important thing is neither of these are, concerning for any sort of malignancy. And then finally, looking at a dermatofibroma compared to a melanoma, the one thing we don't want to miss is melanoma. And the white scar-like patch, it's nice to, or it feels good to kind of, you want to kind of use that as a crutch to be able to call all dermatofibromas. But the problem is, some melanomas have some kind of structures that I think, if you're not used to looking at these lesions, can kind of resemble that scar-like patch. Here in the melanoma on the right, I know Dr. Buchanan didn't talk about these today, but we actually have a negative pigment network here. So you just need to look at the lesion from kind of a bird's eye view. On the right, we certainly have multiple colors and asymmetry, atypical globules, irregular margins. So don't get too focused on one feature of any of these lesions under dermoscopy. Sometimes you got to take a step back, because that one on the right certainly deserves a biopsy. So, and if there's any question, of course, is this a dermatofibroma? If there's any lesion, if there's any characteristics to it that make you feel like it's atypical or it could be malignant, you might as well just go ahead and do a biopsy. So just a little bit about dermatofibromas. Now that I've talked about them, I guarantee in practice, if you're not a dermatologist, you're going to start seeing these all the time. So many people have these. They may or may not mention them to you, but they're most often found on the lower extremities of women. They're firm, skin-colored, pink or slightly pigmented papules or nodules, and a good clinical kind of sign that will let you know that this is a dermatofibroma is the dimple sign. And what that is, and I'll show you a picture, an example on the next slide of what it exactly looks like, is that when you put pressure laterally to a dermatofibroma, it'll cause the skin to pucker inward, or a dimple. And oftentimes, if you ask your patient, how did you get this spot, they'll let you know that it happened after they kind of cut themselves shaving, or they got a bug bite there, so secondary to some form of cutaneous trauma. And this is just a good example of the dimple sign. So this person is, applying lateral pressure, and you can see that the skin is puckering inward around the lesion. So why did I choose this case? I just wanted to highlight the dermoscopic features of DFs and contrast them from benign nevi. Give you guys some, kind of clinical tools to put in your toolbox to delineate what's a dermatofibroma versus what's a nevus. And then, really for patients, you want to try to reduce the amount of biopsies of these lesions because they're completely benign. But if there's any question, of course, you want to biopsy if you think that there's, any possibility of being a melanoma. And then there are my references. I just used that one paper from JAMA.
Well, that's terrific. So as you see this comparison, and we appreciate this, Dr. Diamond, something that's very commonplace, but could be potentially confusing, but some help in terms of differentiating it. Dr. Davis, I have a quick question. I was looking to see if we had any others. I don't see anything in the chat. If you were going to biopsy something that we felt like it's possibly a dermatofibroma, or most likely a dermatofibroma, but you're not sure that the patient would come back to let you look at it in 3 months or 6 months to see if there are changes in that sort of thing, what type of biopsy would you recommend? Is this more of a shave, more of a scoop, more of a punch?
If that question is for me, Loretta Davis, rather than Davis Diamond.
Oh, sorry. Well, yeah, Dr. Davis, that'd be perfect. Yeah, I'm sorry.
So
yeah, I didn't know who. Yeah.
Yeah.
Ahead,
So usually these spots are very small. Usually you're talking 3, 4, 5 millimeters, although they can be bigger. So because the pathology is deep and they're palpable, we usually do a punch, my opinion, rather than a shave. And that's, and usually you just pull it together with one suture and it looks pretty good. I do tell my patients though that these do not need to be removed. If I'm usually pretty good. And if I'm convinced it's a dermatofibroma, I talk people out of it, because you're swapping what is a scar, with that stellate center for another type of scar. So that you're swapping that little bit of fibrosis for another scar. So, oftentimes not giving them a lot of benefit by removing them unless you're shaving over them or nicking them, that type of thing. And they're always traumatized. But if you don't know and you're not sure, then I would recommend a small punch. And usually that encompasses most of the lesion. Some of them can be larger, and so you might have to excise them. But most of the times these are amenable to a punch. And I will also say that most of the time people who have one dermatofibroma have two dermatofibromas. And if you start looking around, you'll find several, because people who tend to make these types of lesions, they reproducibly make this type of lesion from, say, an insect bite, mosquito bite, or a little folliculitis.
Well, thank you, Dr. Davis. Now, Dr. Diamond, I'm not going to ask you to editorialize on whether she got that right or not.
I have 100% faith in Dr. Davis and everything she says.
A little confusing when your resident's name is Davis. That's right.
Good answer, Dr. Diamond. Dr. Diamond, is there anything that you would share relative to the incidence of these dermatofibromas in light-skinned individuals versus dark-skinned individuals?
I mean, I think in particular, I think people with lighter skin will generally, bring it up to us as dermatologists more often because they might be a little more cosmetically displeasing. But I would say the incidence is pretty similar overall. I mean, we see this on, Fitzpatrick 1 to Fitzpatrick 6. I don't think that there's a huge kind of, any sort of racial kind of bias for these things to grow on one person over another.
Perfect. Well, I still don't see any questions in the chat, and I'm looking quickly across the participants, and I don't see any hands raised. If I'm missing something, please someone jump in. But since I don't see anyone, I think we can move back to Dr. Buchanan then and allow Dr. Buchanan, if you would, you have a case to share with us. We still have some time. And thank you again, Dr. Diamond, for that, and Dr. Davis for your expert commentary.
Thank you.
Can you guys see my screen? Okay.
We can.
Okay. So I'll go through this swiftly. So this was a patient I saw a couple weeks ago, 72-year-old female, lighter skin type. She had a mole of concern on her lower back. She does not have a history of skin cancer. That's kind of what it looked like up close. She didn't really bring it to my attention. I just kind of noticed it, it was dark. So the first thing I usually start with is, well, what's kind of my clinical differential? So I thought about melanocytic nevus. Is it a seborrheic keratosis, a lentigo, or, could it be a melanoma? Didn't really think it was a melanoma. I mean, you saw the clinical, right? And it's very symmetric, pretty well circumscribed. So I think that's important before you even put your dermatoscope on there. And so this is what it looked like with dermoscopy. And so let's kind of go through what we talked about last month. So our first step, we need to decide, is it melanocytic or non-melanocytic? So, you can look at this and right off the bat, you see a network, right? You see a network and you see dots and globules. So that right there, this is a melanocytic lesion, okay? So I have the network, which like we talked about, fades at the periphery. And then you do see these little dots, and they are, for the most part, located on the network lines and also sort of between the network lines, which is important. And then we kind of go through our pattern recognition. So it has, we could probably debate about the colors. I'm not the best, but in my mind, this has like a couple of colors, right? Dark brown, light brown, maybe you could say tan. But it's fairly symmetric. You could look at the area on the left and say, well, I'm not so sure. Like, is that a tan brown structuralist area? But, overall, this is a symmetric pattern, and overall it looks organized. So then I kind of asked myself, okay, well, does it have any melanoma specific features? And we talked about these briefly last month. And so, these are kind of the schematics that represent these types of things. And so, it really didn't have any of these features. Okay. Sorry, okay. So then we kind of put it all together, right? So this is a benign melanocytic nevus. It's the sort of reticular globular pattern that I talked about. And then you reassure your patient, okay? And so I like this case because I usually think about things in black and white. And so I think with Nevi in particularly, you do have to kind of appreciate just the overall symmetry, because everything is not going to be perfect. Okay. But another kind of helpful clue and why I chose this case is because two helpful points. So you can see dots and globules, and if they're located on the network lines, that's usually a good sign. And then if they're located in the derma papilla, which is, the white space between the holes, that's what we call a target globule. And that is also pretty typical of Nevi. Okay. And so this is just an example, like we talked about before, typical versus atypical dots and globules. And then in a melanoma, they will often be focally located or located asymmetrically. Along with here, you have another beautiful like negative network that you see in a melanoma. Okay. So, I just kind of think about in this patient, how often would you monitor? Maybe you recheck it every year. She doesn't really have any history of skin cancer. So I'm just kind of seeing her on a yearly basis. But of course, I always say, if you feel like it's changing, you call me and you schedule an appointment. And then I just, was thinking in terms of educational purposes, if you are concerned about a melanoma in the future, what type of biopsy would you perform? So that is all I have.
Thanks again, Dr. Buchanan. Great case. Again, looking in the chat, I don't see any questions. We've got a room full of family medicine residents. I know that residents are curious and skeptical. So there's bound to be somebody in that room that has a question. Would love to hear from someone or any of you who are out there participating.
And this is Anthony from the Family Med Room. We actually do have a resident with, she says a few questions.
Well,
but
no.
We'll see
I
how
don't-
many she
it's-
asks.
And I'm gonna ask only one because I forgot the rest of them. Since it's a big group.
Well, tell us who you are.
My name is Darshana. Can you go back to your last, like the one that was not a melanoma? It kind of looked like it was irregular. Can we why did it have melanotic features?
Dr. Buchanan, can you do that?
Yeah.
Or irregular globules or something like that was what, like you showed us a picture of, like you showed us this and then you showed us that chart.
Yeah. So I just kind of want, clinically, let's just go. There is a good picture. Well, I think this is kind of the hard part about dermoscopy, right? You can look at it and you can really start to go down a rabbit hole. But a lot of times with Nevi, especially in an older patient, you can see somewhere where the skin has thinned, the network might not be quite as visible. But, like I kind of mentioned in this pattern, look at kind of the overall, you have this kind of fading of the network here. And like I brought up, you have the dots that are located on the network lines and then these kind of target globules, right? But overall, this is a benign pattern. Like I said, you could kind of think like maybe it's a little bit asymmetric because you do have this area where the network isn't quite as visible. But nothing is going to be perfect. And that was sort of the reason that I chose this case, because it's pretty easy to see when something is just, a classic nevus pattern, but just kind of keep everything else in mind when you really start to learn dermoscopy. you know, I have to kind of check myself a lot and just, you know, kind of take the whole picture into account in context with the patient. Because, you know, she also said this has been here, you know, I think she said her husband had looked at it before or something, but I do understand what you're saying, and I appreciate you saying it, because I still, you know, have those same thoughts, you know, but it's kind of like that's why you're gonna see that patient back too. And Dr. Rabinovitz might want to comment further, but I did send this to him just to double check.
So basically on this screen, you're not seeing the image quality as good as on other screens, or actually even on an iPhone. And I looked at this picture on the iPhone that Dr. Buchanan sent me, and the areas where you see which are relatively structureless really are not structureless. That is, there are some lines in here which you really can't see. Based on this picture alone, it would possibly be considered an equivocal lesion only because of this area here. But the problem is this is not the true image quality if you saw it with your dermatoscope or even with your iPhone. Some of the features which are characteristic of a nevus with congenital-like features, as Dr. Buchanan just mentioned, is that you have dots on the network, as well as you have these dots in these holes, and these are called target globules, which are characteristic of a congenital nevus or a nevus with congenital-like features. Dermoscopy can't be done in the void. That is, you need to do it with your clinical impression as well. And the combination of clinical and dermoscopy is certainly suggestive of a nevus with congenital-like features. If there were any question marks with the patient, I might see the patient back in 3 months and do what's called mole monitoring, where you take another image, compare the two. Melanomas change, nevi stay the same. And I would be convinced that this lesion would stay the same. But if there's any question marks, I would have the patient come back in 3 months. And then we put it in the bucket of lesions which are benign.
Thank you, Dr. Rabinovitz. Well, we're drawing close on time here. I want to thank Darcia for asking that question. Obviously, you picked up on something that the rest of us could see. And as Dr. Rabinovitz pointed out, that's not 100% representative of the way it actually looked in the dermatoscope. But your eyes saw what we saw, and Darcia, you pointed that out. And thank you for helping us to get a little bit more clarification on that. So the key question for me today, and I'll just kind of wrap this up so we can turn it back over to Rhea, but is when do you biopsy? And I would think that would be when it's suspicious, when the patient is concerned or needs to be reassured, or when you are concerned and need to be reassured and you're not sure the patient will follow back up. I will point out that for all of you, whether you're in the residency or if you're a primary care provider who's participating in this, all of you are much more likely to see these patients come back because they're your patients for other issues, as opposed to a dermatologist who's only seeing them for this one issue. So keep that in mind as you're dealing with your patients and whether you trust them to come back to be looked at or not. So that's it for me. That's going to wrap it up. I want to thank the presenters and thank Darcia again for asking the question. And with that, I'm going to turn it back over to Rhea.
Okay. Thank you very much, Dr. Patton, for leading us through the presentations and discussions. And thank you to Dr. Buchanan, Dr. Diamond, and for those who asked questions, Dr. Rabinovitz, Dr. Davis. Thank you for all your contributions. Kenza has put the CME code into the chat. If there are any questions, you can contact her. Moving forward, we'll need volunteers from the clinics to present case studies for future sessions. We do have some fourth-year medical students who have volunteered to present some cases too, so we will be seeing some new faces. And to our TeleDerm clinics, we're asking you to fill out a very brief questionnaire so we can get feedback and comments from the TeleECHO TeleDerm sessions. So please, when you receive that email, please take a few minutes to open the email and answer the questions. It's less than 5 minutes, and send feedback to us. Our next session will be Monday, August 1st, back to the first Monday of the month. And Dr. Buchanan will speak on the many faces of Nevi Part 2. And we will have case presentations by Dr. Sam Walling from Lee Medical Arts and one of our 4th-year medical students, Hannah Nazer. So thank you all for attending and participating. We have, by my count, we have close to 50 people present today, thanks to the large group in family medicine, but I'm really thrilled at the attendance that we have here today, and I hope that we can keep up the momentum. So if there are not any other questions or comments, I want to remind our TeleDerm Hub people to stay online for a few minutes for our wrap up, and the spoke clinics and other guests can now sign off. Thank you for being here and have a good week. Oh, and one other thing. Good news is that I've just received a couple texts during the session, and Dr. Brenda Santiano, who will be our new program manager, is arriving in Augusta tomorrow. She's been driving cross country, and so she will certainly be here for our session on August 1st. So that is very good news. And so now I'll really say goodbye to all these folks, people and guests, and just ask the Hub people to stay on for a couple more minutes.
Thanks, everyone.
Thank you.
I think this is it.
Okay, so how did we do?
Great, great job today.
Yeah, I think things went well, and I feel like we're really getting the hang of it and are comfortable doing all of this now. So so that's good. And anything else?
Kendall, you did a great job.
Thank you.
Yes, that's right.
Tried.
Absolutely.
I'm a little confused with the CME. She sent the 4-digit, but do you what do you text that to? I guess is all the information in there in the chat?
Yes.
If I can do it.
Yeah, I wasn't able to get it last time either.
Yes, it's in the chat. It's 9089.
So all you do is text that.
Yes.
I didn't try that.
So you have to text it to some number though, right?
So you text.
So you should have the number.
The number is not there. That's just the code. So you need a number.
Yes, but usually, so the text is the number is 833-765-0126. Usually we send an email to thank everyone for the participants, and then we include the number.
I see.
So they'll have the number and the code, that 4-digit code, in one email post.
Yes, so
Okay, good.
I wonder if it'd be easier to add the whole thing to the chat at the end. They
Yeah.
don't have to go back to the original email.
Yeah, I think doing both would be great. And of course, we've got the non-registered but actively participating family medicine residents. And now, thanks to Rhea, we got their email addresses and names. So that would be good.
Well, we send each of those attendees in family medicine
That's good.
that email.
I have a question. Do the family medicine residents have access to a dermatoscope?
They've been ordered, I know they ordered 2 so that they have one in their clinic, and then whenever they come work with me, they have one.
Okay, good. What level resident do you get that comes over to your clinic, Kendall?
They're usually in their 3rd year.
Okay,
Yep. They're pretty good. They're pretty eager, so it's
bet.
nice.
well, this is kind of like musculoskeletal injuries for primary care people. It's just common. You're going to see a lot of skin lesions. You're going to see a lot of bumps and bruises. So this is good.
So just for your knowledge, there actually is a family dermatology residency program. A family practitioner at the University of Texas in San Antonio has a 2-year derm residency program for family practitioners.
Oh, wow.
So, yeah, so it's quite good. And he's one of the experts here in the United States, and he is a family practitioner.
Would he be someone we would want to tap for a didactic at some point for this group?
I could ask him. I could certainly ask him. He is a personal friend and colleague. Why not? I mean, I think it might be very, very good to have someone with his expertise who's a family practitioner give a lecture, and he's quite dynamic. He's a very, very good speaker.
Good.
I'll ask him. You give me approximate time date, and we'll see if we can make it happen.
As we think about lining up the course, I know we've got a few that are already kind of in queue, but right off the top of my head, I'm not sure where we're going.
Sure. He has a very good lecture on skin of color. That is, once they have the basics in terms of nevi, dermatofibromas, he gives a very, very good lecture on this particular subject, because 70% of his patients in San Antonio are either Spanish speaking or of a low income.
Yeah. Well, that sounds like something for the fall, maybe for us. That would be good.
Okay, I think that about wraps it up. Thank you all for your participation as we move forward.
That's great. Dr. Buchanan's on the move. We better hurry up.
That's
Yeah,
right.
right.
I hate being here by myself. I told them, I'm like, leave me 2 lights on. So
All right. Well, thanks, everyone.
Okay.
thank you.
Thank you.
Bye-bye.
Appreciate it.
Bye-bye.
Bye.
Bye.